Hi, everybody. Welcome to today's Student-Led Journal Club presentation. My name is Anne-Marie Parker. I'm a research associate on the Joplin campus of KCU. And today I'm going to be introducing student Dr. Mei Lee. Student Dr. Lee is a third-year medical student at Kansas City University from Vancouver. During undergrad, she studied global public health and was a student athlete in swimming at New York University. She's currently working on research in pyoderma gangrenosum, a rare neutrophilic skin disorder characterized by a skin ulcer with undermined erythematous borders. May is currently interested in pursuing dermatology and internal medicine. In her free time, she loves learning new skills for jump rope and hunting for the best cheese curds in town. Take it away, student Dr. Lee.
Thank you. Well, good afternoon. Hope everyone is having a fabulous Friday. My name is May, like Anne-Marie just introduced, and I'm currently a third year at Kansas City University, and I am going to be presenting to you today regarding a very interesting article I recently stumbled across upon, and it is about botulinum toxin use in Hidradenitis suppurativa by Manisha Ravi as well as Dr. Trinidad. And so first off, we're going to start off with a little bit of a example case. So a patient comes in complaining of cyst under the armpits. And unfortunately, Miss Jane Doe, who is a 32-year-old female, you notice some painful nodules and drainage from her underarms and groin. And some past medical history include she's actually a current everyday smoker. And her BMI is also 30. And so if you guessed Hidradenitis suppurativa, then that is correct, since that is the topic of today. And why is this very important? Well, Hidradenitis suppurativa, or HS for short, has a really major psychosocial impact. There is a twofold increase in the rate of suicide in patients with HS, and it can severely affect the quality of life. It affects approximately around 1% of the population, and unfortunately disproportionately affects females and people of color. So what is Hidradenitis suppurativa? Well, it is a chronic inflammatory skin disease that typically occurs post-puberty, with the highest prevalence around the second and third decades of life. It is characterized by some deep-seated painful nodules, abscesses, sinus tracts, as well as scar formation. That is through that cycle of healing and then skin breakdown. And it is typically seen in the intertriginous areas, such as the axilla, the groin, or the inframammary folds. And so the etiology and pathogenesis, it is actually generally an apocrine gland dysfunction. And so the apocrine sweat glands, in contrast to the eccrine sweat glands, actually opens into the hair follicle. And so they're in greater concentration in areas where there's more abundant hair follicles, such as the axilla or the groin, whereas the eccrine sweat glands actually just are more abundant all over and open up straight onto the skin. And so it kind of starts off with occlusion and inflammation of that hair follicle. And along with some dysregulation of the innate as well as an adaptive immune system. There's also some dysregulation of the skin microbiome in those regions. And so the occlusion of that sweat gland and hair follicle leads to dilation and then further rupture of that gland. And the rupture will end up causing leakage of the follicular contents, keratin, as well as bacteria into the surrounding dermis, which will then initiate a large inflammatory cascade. The predominant bacteria that has been found in those areas is Staphylococcus lugdunensis. And so then that kind of vicious cycle of skin breakdown, inflammation, as well as that dysregulation and elevation of the pro-inflammatory cytokines such as TNF-alpha, IL-17, or interferon gamma kind of perpetuates that inflammation. which can lead to that scar formation and then those abscesses. And it is also associated with some sort of a genetics. There is positive family history in approximately a third of patients with hidradenitis suppurativa. And researchers think that there might be some sort of link to a mutation in the gamma secretase pathway. However, it is not 100% certain as of yet. And some pathology here as well to show of some tissue that was acquired by punch biopsy from the gluteal region. Number one, we can see here some hyperkeratosis or thickening of that stratum corneum, as well as papillomatosis, which is where that dermal papillae kind of is above the surface of the skin, which can create kind of a rough or undulating surface to the skin. And number two, here we see a hair follicle that also has some keratin buildup around it and some inflammation surrounding. 3, here we see some fibrosis. 4, an abscess-like accumulation of inflammatory cells. And then number 5, here we see a sinus tract with surrounding inflammation. And what are some risk factors for hidradenitis suppurativa? Well, as we saw with our example patient who was an everyday smoker, smoking can certainly be a risk factor. Obesity could also be a risk factor and potentially even pathogenic, as there can be increased skin folds, which can cause moisture buildup and increased friction, which can decrease the skin barrier and integrity. Tight-fitting clothing as well can also lead to excess friction or moisture retention. And like many skin diseases or other medical conditions, stress can be a big part in flares or exacerbation of the disease. And so how do we diagnose this? The Dessau definition, they should meet 3 criteria. So the 3 criteria include the presence of typical lesions, lesions seen in typical locations such as the intertriginous areas, and chronicity of the disease, which is defined as 2 recurrences in 6 months. And how do we classify severity? It is by something called the Hurley stages. And the Hurley stage 1 is considered mild disease, where we can see that deep-seated painful nodule or abscess formation in a fairly localized area without the sinus tracts or scarring. And in moderate HS or abscesses as well as nodules, but this time including the sinus tract formation as well as scarring, but still in a fairly localized area. And in severe HS or Hurley stage 3, we can see a more diffuse wide distribution involving all 4 of those aspects that we talked about, the sinus tract, scarring, and abscess, and painful nodules, but in a wider distribution. And so some of the traditional treatments for HS include lifestyle modifications, so decreasing risk factors such as smoking cessation, weight loss, wearing looser, more breathable fabrics, or antibiotics if there is a super infection or something else going on. Topical treatments can also be used, such as retinoids, antibacterial soaps, or benzoyl peroxide. And biologics, adalimumab, which is an IL-12 inhibitor, has been FDA approved for HS treatment. However, other biologics, such as infliximab, a TNF-alpha inhibitor, has also been used off-label as a second-line choice. And if the disease is extremely advanced, surgical debridement may be needed. And as for almost all of the severity stages, proper wound care is best to help prevent as well as treat existing active lesions. And so something a little fun, the brain potentially would have wanted a little Botox for his wrinkles before going to the pool. And generally, the population probably thinks of Botox for cosmetics. However, Botox or botulinum toxin can actually be used for a lot of medical conditions. And so here I'm going to start talking about the article that I've chosen, and it is about botulinum toxin use in hidradenitis suppurativa. And so the methods that they used to choose the articles to review included a search with keywords with variations of hidradenitis suppurativa, Botox, and botulinum toxin in 3 databases. The inclusion criteria included any of the non-review articles that reported use of botulinum toxin in HS. Both authors first screened through the title and then the abstract before screening through full text. In the end, they decided to include 7 total studies, 5 case reports, 1 prospective study, and 1 randomized controlled trial study. And some of the population characteristics in the articles that they reviewed, the average age was 37.6 years with a range from 6 to 55 years old. All 3 Hurley severity stages were included, and 61.3% of these patients had some degree of hyperhidrosis or excessive sweating. And so Botox has actually been used for hyperhidrosis in the past and has been seen to as a second-line treatment or for those who have treatment-resistant hyperhidrosis. And Botox has been seen to paralyze and thus decrease the sweat amount from eccrine sweat glands, or that type of gland that opens directly onto the skin. And a meta-analysis comparing Botox versus placebo normal saline injections showed a greater than 50% sweat reduction in 2 to 6 weeks, as well as the effects lasting from anywhere from 3 to 6 months. And this is generally for that axilla area. And so the administration of the Botox in the study that we're talking about for hidradenitis suppurativa, in 5 articles, they injected the Botox in the common areas such as the axilla, inframammary folds, or the groin. And some other studies, they also injected it into some secondary areas such as the perineal region, postauricular region, or the torso. The amount of Botox that was administered did range quite significantly. For the axilla, there was 50 to 200 units, groin and inner thighs, 40 to 200 units. In the prospective study, they used 100 units across the board. And in the randomized control trial, 50 units was used for the axilla area, 200 units for the groin, and 600 units for the perianal or perigenital area. The technique used for Botox administration included intradermal injections around the borders of these active lesions or disease, using caution to avoid direct injection into those active nodules. And what were the results? The results were actually very beneficial. 66.7% of the patients actually achieved complete remission, 4 patients after just 1 treatment, and then 2 others after 2 treatments and 5 treatments respectively. And the remaining patients achieved partial remission, which was defined as a decrease in pain, a decrease in drainage, as well as increased quality of life. And the remission, or these results, lasted for a minimum of 6 months. And for 2 of the patients who were treated multiple times, they had no recurrence, which could potentially lead us to think that there might be a cumulative effect as well. And in all 7 of the articles that were reviewed, no adverse events were reported. And so finally, some discussion. So HS is generally a disease involving the apocrine sweat glands, whereas hyperhidrosis primarily affects the eccrine sweat glands. And we know that Botox does decrease sweat production in eccrine sweat glands by inhibiting acetylcholine release from its vesicles, as the botulinum toxin does inactivate SNARE, that SNARE complex, and so subsequently will prevent cholinergic stimulation to decrease sweat from the eccrine sweat glands. However, the proposed beneficial effects of Botox in HS can be potentially similar to that reduction in eccrine sweat glands. And so they're thinking potentially they're also decreasing sweat production in apocrine glands. And that can help temporarily heal active lesions and potentially avoid recurrence by altering that pro-inflammatory skin microbiota. And it is potentially speculated that those interactions might be due to indirect interactions or spatial proximity of those two glands. And so that might be the reason for their special relationship and how Botox might lead to decreased sweat production in apocrine glands and help patients with HS as well. Thank you. Are there any questions or comments?
Great presentation, student Dr. Lee. Thank you so much.
Thank you.
Again, just to reiterate what she just said, does anybody have any questions? Feel free to unmute and just go for it or type in the chat.
May, I've got a couple for you relevant to the population of patients that were treated. Was there a persistent, or was there a common denominator for the BMI? Was it higher than in all the patients treated?
I believe so, yes. Oh,
Okay.
sorry, did I?
No, you said something about that. It said it ranged up to 33 or something.
Yeah.
I just wondered if that was small. It's a sample volume that's not big, correct? But,
yeah, it wasn't that big, the sample size. However, it is generally more of a risk factor.
Yeah.
Not all patients potentially could have a higher BMI, but it is generally seen that it leans that way.
You mentioned various sites. Is there one that somewhat predominates, or is it equal distribution of most sites?
Oh, yeah. The ones that predominate more are probably the axilla, the groin, or the inframammary folds, but it can also occur on the torso as well.
Yeah. The slide that you showed that showed the various stages. What part of the body are we looking at? That almost looked like the leg, but I couldn't.
I think that was, that's the underarm area.
That's the arm. Armpit.
So
okay, I see. Yeah. Okay, I got you. All right, thank you. Then on the scars, it said, and I say on the scars, that's as the botulinum is given, you're in the technique of injection from the nodule, etc. That must take some skill set to make sure that you're injecting, but not inside a tract. Any of those things around that. I think it's pretty hard to avoid those sites sometimes. They comment about the art of injecting?
No, not really, not in this article, but I think, it is pretty difficult because from what I've seen, at least for hyperhidrosis, it's generally, obviously, it's kind of the entire underarm area that you inject a little bit. But yeah, so for this, it would be difficult to also avoid those lesions at the same time.
My last question to you, is there a number of Botox injections that you can receive that say, no, it's too soon for another one, too often, etc.?
Oh, that's a good question. I'm not 100% sure, but at least for HS, I'm not 100% sure, but the patients seem to, it's just when they feel like there's some sort of recurrence, then they would come back and receive treatment again.
Yeah, I'm just wondering if there's a caution after X number of treatments and what frequency you're administering the treatments. I don't know.
Yeah, I'm not sure either,
Yeah.
but
I thought your
as
slides were
yeah.
really good and your
Oh, thank
content
you.
explanations were very good. Well done.
Thank you. Thank you.
Thank you.
Dr. Wolf, do you have a question?
Sure, thanks. I also enjoyed your presentation. My question is betraying my ignorance when it comes to the sweat glands, because I've forgotten a lot of that stuff. And we always talk about the sweat glands being innervated by sympathetic cholinergic fibers is what the figures always show. And you mentioned that that was the eccrine sweat glands, and the apocrine sweat glands, I believe, actually have adrenergic innervation. So I was curious if they had also tried various long-acting adrenergic agonists, like or I don't remember if or long-acting adrenergic antagonist, I guess is what I would be wanting to use if I was trying to impact the apocrine sweat glands, and if that had any effect, or where you think. I guess you alluded to that a little bit. I mean, if the eccrine, you're getting rid of this. What is the benefit of eliminating the sweat from the eccrine sweat glands on the pathophysiology of this disease? Is, I guess, the question I'm trying to ask.
Yeah. So I think that is still a little bit up in the air. In this review, they kind of said they're not 100% sure as to what the actual mechanism of benefit is, but they're proposing that potentially it could also decrease apocrine sweat reduction. But they know for sure, at least for eccrine, because Botox has been used for hyperhidrosis for quite a long time. But this is just some, I guess, more speculation. There isn't a really good explanation as to really why Botox seems to be beneficial for HS currently.
Dr. Staudinger, you have a question?
Yeah, thank you so much for your presentation.
Thank
I enjoyed, especially the last slide. That's all, folks. I'm a big Warner Brothers cartoon guy, so appreciate that. How many adverse events or side effects or black box warnings or drug-drug interactions are you aware of with Botox injection?
I believe the main adverse effects are more localized and have more to do with the injection itself, such as hematomas or infections if there isn't, if the skin doesn't heal properly. But I'm not 100% sure past that.
That can affect how Botox works and interacts. That's something you could likely think about. Are you thinking about Botox as a therapeutic in your future practice?
Potentially. I think the one downside with this is if it hasn't really been approved, Botox can be very expensive. So,
yeah, so that was my other question. How many uses for Botox can you name? And there's clearly migraine is one of the more obvious.
Yeah.
What else?
I think there's also a lot of people can get Botox in their masseters for TMJ dysfunction as well. So I feel like anywhere, any kind of disease or that can cause pain due to like excessive muscle contraction or tension could probably benefit from that as well. Yeah, but I know for masseter injections, it requires a lot because a big muscle requires a lot more than just a couple units. So
I had, yeah, it's not so much a question as a comment. it's fascinating to me that Clostridium botulinum toxin can be used as a therapeutic, and it just highlights a notion as a pharmacologist to me that dose is incredibly important in life and in medicine. As Paracelsus, the father of toxicology, tells us, everything is toxic. It's just a question of dose. So from that aspect, I completely enjoyed your presentation. Thank you again so much.
Thank you.
Any other last minute questions? If not, again, thank you so much, student Dr. Lee. It was a great presentation. I really enjoyed seeing the final product after the practice run. It was really good before, but it looks really good now too.
Thank you.
All right. Yeah, thank you everyone for being here. We'll see you hopefully again next week for this weekly series. Next week's presentation is by student Dr. Ramirez. I believe they're an anatomy fellow. Don't quote me on that, but I think they are. So thanks again, everybody. Hopefully see you next week. Have a good weekend.
Have a good weekend.
Thank you. Have a good Friday.